Okay, so the first set of dysrhythmias that we're going to talk about are the ventricular dysrhythmias, or also called arrhythmias. Just the terms are used interchangeably. Ventricular arrhythmias are potentially deadly because the ventricles are the ones that are ultimately responsible for cardiac output. So if my ventricles aren't contracting the way they're supposed to, then my output is not happening the way it's supposed to. And as you can imagine, that can lead to some problems. So with premature ventricular contractions, these are also called PVCs. What this means is that there is some sort of ectopic stimulus on the ventricles down at the bottom of the heart that is causing it to beat too fast. The underlying rhythm is actually normal. You'll just have these really crazy looking QRS complexes every once in a while. Usually there's two types. There's unifocal and multifocal. So the very top strip, this is unifocal. They look exactly alike. That means it's coming from the exact same spot on the heart. It's just irritating it at the same exact place, so the beat will look the same. This bottom rhythm is multifocal PVCs because this PVC looks nothing like this PVC, but it's happening in the ventricular complex, so you know it's a PVC. So unifocal is at the top because they look exactly alike, and multifocal down at the bottom is coming from different places. When you have every other beat is a PVC, that's called bigeminy, and if you have every third beat is a PVC, it's called trigeminy. When you have two PVCs together, just like two people, it's called a couplet. If you have a bunch of couplets happening at once, it's called V-tach. And V-tach occurs when there are 3 or more consecutive PVCs. Just to make it even more fun, you've got non-sustained V-tach and you have sustained V-tach. So with non-sustained V-tach, you've got V-tach that persists less than 30 seconds. Now trust me, it's enough to freak you out. Your patient's going to feel funny. They can usually feel it happening, but sometimes the heart just kind of gets irritated and then it flips back out of it. With sustained V-tach, when you have 3 or more consecutive PVCs at a heart rate of greater than 100 and it's lasting more than 30 seconds, then you have a problem, obviously. Let's talk about some of the causes. So anything that is irritating the ventricles or the heart muscle, it can be ischemia, like a heart attack. It can be hypoxia, like if you're not getting enough oxygen. Caffeine, stress, anxiety. So I'm sure a lot of you nursing students are going through those right there. And we do sometimes have PVCs. You occasionally will throw a PVC, especially if you've got a lot of stress or if you've been drinking a lot of caffeine. Reperfusion of the heart muscle after stent placement. Remember I told you about that? It's not uncommon to see a couple little PVCs. Again, that heart's trying to get used to being reperfused. You can have an electrolyte imbalance that will cause PVCs. And anytime you've got infection or trauma or surgery happening, that can also cause you to have PVCs. And the opportunities can increase with age. This says most patients don't know that they are having PVCs, but if you're in tune to your body, you kind of can feel it, kind of like a flutter in your chest. You'll feel it. Increased levels of PVCs will have an increase in the effects felt by the patients. They'll feel their heart palpitating. They can have dizziness. What do you think causes the dizziness? How about decreased perfusion to the brain? Chest pain, and again we got decreased perfusion to the heart muscle. You can have a decrease or even an absence in the pulse depending upon how many PVCs we got going in a row. 3 or more in a row and you have V-tach. And again, I told you non-sustained will usually be done within 30 seconds. If it lasts longer than that, you have sustained V-tach, and that's whenever your ACLS guidelines need to kick in. You'll end up with what's considered ventricular tachycardia, and that's not very good. Ooh, and back it goes. Okay, the treatment options. Oxygen. Notify the physician if the patient is symptomatic. The doctor will start giving you orders, so the first thing you can do is slap some oxygen on them if they aren't already on it, because if that heart muscle is not perfusing the way it's supposed to, they're going to be a little hypoxic. There will be medications ordered, such as lidocaine. What are we doing with lidocaine? What do you think? Remember I told you that the whole reason that we're having ectopic beats is because there's some sort of area that's overstimulating the muscle. So lidocaine will help numb up that area and hopefully stop whatever is irritating the muscle. Amiodarone is another antiarrhythmic that we give patients. And of course, eliminate stress or caffeine. Yeah, that's going to happen. Let's talk about atrial fibrillation. So, with atrial fibrillation, this is characterized by total disorganization of the electrical impulses in the atria. There are multiple areas of ectopic irritation, causing a complete loss of effective atrial contraction. Your ventricular rates, so you can see we've got some ventricular beats that are coming through here. 1, 2, 3, 4, 5, 6, 7, 8, 9 of them have made it through. So it just depends on the number of impulses that pass through the AV node that then tell the ventricle to contract. So AFib with a controlled ventricular response usually means we have a rate between 60 to 100 because remember that's what your normal SA node is supposed to be beating at. AFib with rapid ventricular response, also called RVR. This is when you have a ventricular rate or a rate greater than 100 beats per minute. So we have some problems with atrial fibrillation. It is very, very common, but you don't have a P wave and you don't have a contraction, and you don't have what's called atrial kick. So you're asking me, what is atrial kick? Well, the easiest way to explain it, if your atria were to just kind of not do anything and let the blood just fall out, about 70% of the blood that's in the atria would fall out into the ventricles. But because the atria are supposed to contract, they actually squeeze that last 30% out. So during atrial fibrillation, they lose the atrial kick because the atria is just kind of, it's fibrillating, it's just kind of quivering. So you lose about 30% of your blood volume because it just kind of hangs out up in that atrium. Well, if you'll see down, that leads to blood pooling because that 30% remains behind. Well, that blood kind of hangs out in there, and when things are in close quarters, it's like, hey baby, what are you doing? And then you end up starting to have clot formation. So that is why atrial fibrillation patients have a high risk for stroke. Okay, ooh. Treatment for acute AFib. So the goals of treatment include a decrease in the ventricular response, prevention of stroke, and let's get them converted back to a sinus rhythm, please, because if we do that, we'll improve ventricular pumping. We usually will give them antidysrhythmic drugs like diltiazem, amiodarone, heparin and Coumadin, which you would understand why we're giving heparin and Coumadin, right? Because we don't want those clots to happen. Diltiazem is a calcium channel blocker, which is also going to impede conduction through that AV node, so you got to be careful with that. Amiodarone is an antiarrhythmic. Again, heparin and Coumadin. We do have newer drugs like Xarelto, Pradaxa, Eliquis. Those newer drugs don't necessarily need labs as frequently as Coumadin does, so they're very attractive. They're also very expensive. So it's just something to be aware of that Coumadin tends to be the go-to because it is an old drug and it's relatively inexpensive. Cardioversion, if the patient is in AFib longer than I think about 48 hours, they'll try anticoagulation therapy and medications for a couple of weeks. If not, then they're going to try to do cardioversion. They're going to still be on anticoagulant after cardioversion, but what we're going to try to do is kind of slap the heart and try to reset it, if it's at all possible. It is done under conscious sedation because we are shocking them, and the patient does feel that. The first thing we do, though, before we cardiovert, is we do a transesophageal echocardiogram to verify that there are no clots prior to cardioversion. Why do you think that is? Well, we don't want to cardiovert them and make everything go back to working the way it's supposed to if there's a clot in there, because what's going to happen to that clot? It's going to get shot right out the aorta and or out into the pulmonary circulation. It's either going to clot up the lungs or clot up the brain, and neither one of those things is very good for our patient. If the AFib doesn't convert, they are going to be on long-term anticoagulants and probably some dysrhythmic drugs. Again, AFib is a very popular dysrhythmia. A lot of people have it, and it can be managed with anticoagulants and antidysrhythmics. Okay, atrial flutter. With atrial flutter, you can see it's a very distinct pattern. So what do you think that means? If this is a very distinct pattern, remember back when we talked about PVCs and I talked about unifocal PVCs? So there was one focus. That's why the PVCs all looked alike. Well, here with atrial flutter, that sawtooth-shaped flutter wave originates from a single ectopic focus in the atrium. The treatment is usually the same as AFib, but it's a little bit easier to find the areas that are being irritated because, as you can see, it's coming from one exact place. This is a 4-to-1 ratio, 1, 2, 3, 4, and then we have a ventricular beat that gets through, and then we have 1P, 2P, 3P, 4P, then there's a QRS. It's happening in a nice regular beat. So with atrial flutter, the most important thing to consider is the ventricular rate. With atrial flutter, when you have high ventricular rates and loss of atrial kick, this means that you have decreased cardiac output, and obviously this can cause very serious consequences. You don't see a flutter in a healthy heart, usually at all. So there's usually other underlying pathologies that happen. But be sure you can identify it because it is very significant with this sawtooth atrial wave going on. Okay, let's talk about a few lethal arrhythmias. These are the ones that are gonna kill you. So VTach, ventricular tachycardia. With VTach, we have a very wide QRS. There is no P wave. Looks like a tombstone because if you let it stay there long enough, you will be a tombstone. Typical rate can be 140 to 180. The patient may or may not have a pulse, and this is often the rhythm you'll see before they go into ventricular fibrillation. So right now we still just have tachycardia. We can't shock this necessarily. So we have VTach with a pulse. VTach with a pulse. They can be sitting there and talking to you, but they can get kind of loopy, and they can say that their heart feels kind of funny. Their blood pressure will start to tank, obviously, because if only their ventricle is squeezing really, really fast and there's very little atrial involvement, you're going to have problems. Slower rates, obviously, a little bit more tolerable because you are still getting some cardiac output. Lidocaine and amiodarone are still going to be your antiarrhythmics. Prepare for cardioversion. It'll be synced, so it's at a lower rate, but the patient's probably going to need some medications because you don't want to be shocking them when they're sitting there talking to you. If they continue to have VTach with a pulse, long-term treatment might require an implantable cardioversion device. Just depends on what else is going on. So here is what it will look like with cardioversion. You can see the big electric spike. And hopefully what happens is it's kind of like slapping the heart in the face, and it gets slapped and then it goes, oh, I remember what I'm supposed to do. PQRST, PQRST. So that's what you hope happens. Causes, anything that's going to irritate that ventricle. So MI, caffeine, sensitivity to stressors, anything like that. Severe electrolyte imbalance, hypoxia, heart failure, drug toxicity, anything that irritates the ventricle can lead this person into ventricular tachycardia. Okay, this is a special type of ventricular dysrhythmia called torsade de pointe. If you translate this literally, it means twisting on a point. With torsade, people will say torsades, but with torsade, This is a very uncommon and distinctive form of polymorphic VTach, basically. It can degenerate into ventricular fibrillation, so torsade is a very emergent situation. Remember we talked about the QT interval being too long? A prolonged QT interval is a lot of times the precursor to torsade. And very frequently it's as a result of a magnesium level. So as you can imagine, one of the main treatments for torsade is going to be giving them magnesium sulfate. Anything that we can do to correct the rhythm. As far as ACLS goes, we can cardiovert this rhythm, but it'll usually recur. You have to treat the cause. You can defibrillate if it develops into ventricular fibrillation, but I don't know about you. I don't want to stand around and wait and see if it's going to convert to VFib. So most of the time you're going to give these patients magnesium and it'll spontaneously resolve once you get the magnesium back up. But you can see this looks like a twisting. And that's literally why it's called that. It'll twist. That makes me dizzy. So what is this rhythm? We haven't really talked about this particular rhythm yet. Oh, wow. Okay, so here are your options. Pulseless electrical activity, asystole, torsade, or ventricular fibrillation. So the answer is actually ventricular fibrillation. So with ventricular fibrillation, it's the same as like atrial fibrillation. It's just the ventricle is fibrillating. So there is no pulse because the ventricle is just kind of sitting there quivering. You have no cardiac output. This is pretty much a lethal dysrhythmia, as you can imagine, because I have no cardiac output. No P waves, no Q waves, you got nothing. You can have fine and coarse. So with coarse, the waves are going to be a little bit more distinguishable. With fine, they're going to be a little bit more flat. If they're really, really flat, it might even look like they're in asystole, and you have to look at different leads to verify what's really going on. Causes, similar to VTach, sometimes it just happens. But remember, with VFib, you're going to have no cardiac output, no pulse, no blood pressure, because the ventricles are just sitting there quivering. What is the only treatment option that will change this rhythm? So we have CPR, defibrillation, cardioversion, or pain medication. So I have fibrillation going on down here. They're just quivering. So the only treatment would be defibrillation. I'm not going to cardiovert because there's nothing here to begin with to convert to in the first place. These ventricles are quivering. There's no rhythm. They are not dancing. Okay, treatment. Defibrillation is number one. Shock. Electrical shock. That's the same thing as defibrillation. Never mind that. Emergency drugs. Epinephrine, atropine, vasopressin, you can read these. These are all medications that could be given for ventricular fibrillation. You'll want to consider emergency drugs, most importantly epinephrine, and then usually what you'll do after you give the medication is do CPR. So you'll try to shock it first, and again that's kind of like slapping it in the face. Just see if you can get that SA node to go, oh, I remember my job now. So you'll try to defibrillate them first, then give CPR to try to get at least as much perfusion as you can. Oxygen therapy, drug therapy, and again, usually it's going to be give the drugs, do CPR, give the drugs, do CPR. You'll know all about that when you get into ACLS algorithms. Okay, asystole. This is bad. This is ventricular standstill. This is the absence of electrical activity. You got nothing. No P waves, no QRS. Always go in and verify lead placement and patient condition, because you don't want to be sitting at the monitor, see this, call a code blue, get 48 people in that room, and have the patient sitting there eating lunch and their leads popped off. You have to check multiple leads, and you will realize that there is no electricity happening out of any of the leads. Only then can you do something about this. But do we shock this person? No, you can't shock dead. You have to get something there to go on first before you can shock it. So what you're going to do is give them epinephrine and or atropine, usually epinephrine first. Then you'll do CPR to circulate the epinephrine and let it kick in. Usually the epinephrine will irritate the heart enough that you'll get some sort of electrical activity going on. Once you do that, then you can decide if the rhythm is a shockable rhythm or not. But always remember, if you see asystole, first go check the lead placement and check your patient. If you truly have no electrical activity going on, you cannot shock this. There is no rhythm there to shock in the first place. You give them drugs first, then give them CPR to circulate the drugs. Hopefully the drugs will irritate the heart muscle enough that you will get some electrical activity. Then you assess the electrical activity to see if there is something there that can be shocked. Pulseless electrical activity. This is my favorite blonde joke. The electricity's on, but nobody's home. You will see electrical activity on the heart monitor, but the heart isn't pumping. So you have to treat it just like asystole, fix whatever is causing it. So you will do the same thing just like asystole. First, go in and check your human. Do we have lead placement correctly verified? Have we looked in multiple leads to see if maybe something just isn't being picked up correctly? If that is all true, then we give them drugs first, usually epinephrine. We give them CPR to circulate the epinephrine, let the heart get irritated, then see if we get an electrical rhythm to go on that we can maybe shock. Usually the prognosis is very poor unless we can quickly identify the underlying problem. One of the cool things, though, about pulseless electrical activity and finding the causes is there are usually H's and T's that cause them. So hypoxia, hydrogen ion issues, meaning acidosis, hypothermia, hypovolemia, hypoglycemia. Then our T's are going to be tablets, meaning they took an overdose. Sometimes you'll see this with overdoses of beta blockers and calcium channel blockers, DIG, and cocaine. Cocaine tends to do a lot of pulseless electrical activity as well. Trauma, tension pneumothorax, cardiac tamponade, and thrombosis because it's blocked the blood flow. So all of these things are things that you want to think about, but the critical thing is to find the underlying cause first so that you can get this treated. Okay, the heart blocks, I'm going to keep going. I know we're at 26 minutes. I'm going to keep going because the heart blocks are kind of a package deal. So your AV block results from an interruption in the conduction of impulses between the atria and the ventricle. It can be total or it can be partial. It can delay conduction and it can occur at the AV node, the bundle of His, bundle branches, whatever it is. There is a block somewhere. So let's start with first degree AV block. With first degree AV block, all that means is that my PR interval is prolonged. This occurs when the impulses from the atria are consistently delayed during conduction through the AV node. This is the least dangerous. You'll see this more frequently than you'll see the other ones. But first degree AV block can progress to more severe block. So this P to R, this interval right here lasts longer than 0.20 seconds. So this rhythm is actually irregular. Sorry. If we were to measure it out, it's regular, just this PR interval is just a little bit too long. So that's first degree AV block. Causes of first degree block: myocardial infarction, coronary artery disease, bunches of different things that can slow that conduction from the or through that AV node. Symptoms and treatment: if they're asymptomatic, we don't do anything about it, we just monitor it. Second degree AV block. So we have second degree type 1 and we have second degree type 2. So with second degree type 1, this is also called Winky-Bach. Also, just to make it even more fun, called Mobitz type 1. So with type 1 second degree AV block, this occurs when each successive impulse from the SA node is delayed just a little bit longer than the previous impulse. That pattern continues until an impulse actually fails to be conducted, and then it repeats again. So you can see here it's normal, then it gets a little bit longer, then it gets a little bit longer, and then oopsie, nothing went through. And then it goes, oh yeah, there it's normal, and then it gets a little bit longer. So it can occur normally in an otherwise healthy person. Just keep track of that. But with second degree type 1, you still have your P, QR, ST, everything you hear, but just that PR interval gets a little bit longer and a little bit longer and a little bit longer until it just forgets to send an impulse through altogether. Causes: same thing. MI, coronary artery disease, DIG, and beta blockers will also cause this. Dizziness, lightheaded, chest, they'll feel it sometimes when it drops that beat. Atropine is your most common drug that you will see to treat that one. Sometimes we have to do transcutaneous pacing to pick up that extra beat until we can figure out what the problem is. Second degree type 2. This is also known as Mobitz type 2 block. This is less common than type 1, but it is definitely more serious. The ventricular rate tends to be slower than in type 1, and cardiac output does get diminished. So the atrial rhythm is regular, but the ventricular rhythm is irregular. It's also more likely to cause symptoms of decreased cardiac output and actually progress to a more serious form of block, which would be complete, and we'll talk about that in just a minute. So you have a P wave that is non-conducting and just drops the QRS, but the PR interval remains constant. That's the difference with this one. So you can see here, your PR interval is exactly the same, and then here we have no QRS after it. Oopsie. So just to remind you, with first degree, your PR interval is just too long. It's longer than 0.2 seconds. With second degree type 1, you have a progressive prolongation of the PR interval until the P wave just occurs with no QRS. It drops a beat. With second degree type 2, your PR interval stays the same, but you have periodic non-conductive P waves and you drop the beat. That leads us to causes and symptoms. Again, drug toxicity, MI, coronary artery disease. Atropine, again, is your treatment of choice for blocks. You can put a pacemaker in because you can't just go on dropping your QRSs. That's going to cause pretty significant problems eventually because that means your ventricles aren't contracting, which can lead to third degree heart block. With third degree heart block, this is a complete dissociation between the SA node and the AV node. So the top part has no clue what the bottom part is doing. With third degree, there is no relationship. You have independent beating of the atria and the ventricles. So you can see here, I got an atrial beat, 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 I got an atrial beat. Here I have a ventricular beat, a ventricular beat, a ventricular beat. So you can see I have two entirely different rhythms going on. I've got an atrial rate of 1, 2, 3, 4, 5, 6, wait a minute, I lost count. 4, 5, 6, 7. So I have an atrial rate of approximately 70 and a ventricular rate of approximately 30. This is a problem. This happens a lot of times when there is something big going on, severe heart disease, a major myocardial infarction, myocarditis, cardiomyopathy, a reaction to or overdose to DIG and beta blockers and calcium channel blockers. Obviously, if my atria and my ventricle are not talking, then I have reduced cardiac output. I can have hypotension, chest pain, all kinds of problems, shock, eventually ending up in shock. This block is very serious, if I haven't said that already. It is life-threatening because there is a very slow ventricular rate and you have significantly decreased cardiac output. So just a little funny that kind of has helped some people. So when we're talking about the AV blocks and the different AV blocks, there's a thing called the story of the AV block family. So with first degree AV block, the wife, who is the P wave, and the husband is the QRS wave. So with first degree AV block, the wife is waiting at home, and the husband comes home late every night, but he always comes home and it's always at the same time. So he's just always late. That's first degree AV block. With second degree block type 1, the wife is waiting at home and the husband comes home later and later every night until one night he just doesn't come home at all. And then he goes through the same cycle. He starts coming home later and later every night, a little bit later, until he just doesn't come home at all. So that's second degree type 1. Second degree type 2, the wife is waiting at home. Sometimes the husband comes home, sometimes he doesn't. But when he does come home, it's always at the same time. So with second degree type 2, the atrial rhythm is regular, but the ventricular rhythm is irregular, the one that's irregular. So eventually you just drop that beat. With third degree AV block, they're on their way to divorce. The wife is at home. She's just like out doing her thing. The husband is out doing his thing. They don't even talk. They have their own regular schedule, and it's time for them to see a counselor, which is a pacemaker. So a pacemaker is an artificial electronic device that helps take the place of whatever electrical issue is not happening with the heart. Most of them are demand, which means they have to wait until there is a lack of electricity before they kick in. Otherwise, they would just keep like shocking, or sending the electrical impulse, and there wouldn't be a reason for it. So most of them are demand. There's all kinds of new technology out with pacemakers. We have temporary, we have transcutaneous, which means across the skin. This is done in an emergency situation. We've got invasive temporary pacemakers for urgent needs. Usually you do a temporary pacemaker until you can get them scheduled for surgery and put a permanent pacemaker in. This is what you will see on the EKG. You'll see these pacemaker spikes. So see this long, big spike here? Then you've got the big spike, and then you've got the big spike, and then you've got the big spike. So this is going to be very important for you, wink, wink, to pay attention to whenever you see cardiac strip. What you hope to see is the spike of the electrical charge and then depolarization, which is ventricular contraction. Then you have the spike, and then you have the depolarization. So you would document that you have capture on this particular pacemaker, because that means that you are getting successful depolarization or ventricular response after every electrical spike. So usually you can see it or feel it underneath the skin. If they're real thin, you can see it. Like here, you can see this, guys. Here's some important things for you to remember. You want to make sure that they don't lift their arms or heavy objects for at least a week after that pacemaker has been put in, because you've got these leads that follow in through this vein, and they actually stitch into the atrium and the ventricle or whatever, wherever the need be, but they stitch in, and you have to let that heal. If you raise your arm and it dislodges these, as you can imagine, you're going to have some problems because it's not there to do the electrical kick that it's supposed to do. Have them stay away from very powerful magnets. They are usually issued a card that explains that they have a pacemaker that needs to be kept in their wallet. Defibrillation. Obviously, we do this for pulseless ventricular tachycardia or ventricular tachycardia, we defib fibrillations. It's always done synchronized because you don't want to shock them in the middle of a contraction. That could be a problem. That's completely messing up the electrical process in the first place. What we want to do is reset the electrical process. Here is an implantable cardioverter defibrillator, ICD, we talked about earlier. Some of the pacemakers that we have actually have an ICD built into them as well. So you need to know, if you have a patient with a pacemaker, you need to know what type of pacemaker they have. Is it monophasic, or is it atrial? Is it atrial and ventricular? Does it have an ICD? This slide is just to give you a visual of what goes on during sudden cardiac death. So I just want to add a few more pieces. I'll go ahead and go to the next slide. It says it's the end, but I just want to add a few closing remarks. So clinical management. Remember primary prevention. That's the health promotion, disease prevention part. This is where we're going to have the biggest impact with patients who have cardiovascular disease. So these are the lifestyle changes: diet, exercise, stress reduction. Make them stop smoking, or don't make them, but educate them about smoking cessation. Nicotine is a vasoconstrictor. If we already have cardiovascular disease, we don't want to give them, they don't want to be taking in another type of medication that's going to be constricting their vasculature even further. Low salt, low fat, no added salt and sugar, have them eat a lot of vegetables, reduce their starch and dairy products. Exercise, just getting people up and moving them around every hour is going to help them. Secondary prevention, this is screening and diagnosis. This occurs after the health problems have arisen. So this just helps them from getting worse. Prompt treatment, monitor heart rate and blood pressure, regular EKGs and echocardiograms, monitor labs and electrolytes. So anything that we can do after they've already got the health problems to help them prevent from getting worse, to help them prevent, help them stop from getting worse. Then the tertiary. This happens after after the health problem has occurred, but this is aimed at returning the patient to their highest level of function possible. This is basically the rehab. Medications, if they need a pacemaker or an implantable cardioversion device, surgery, cardioversion, whatever it's going to take to help restore them to their highest function possible. Please make sure that you go back through these dysrhythmias. It really takes a while to get their patterns down in your head and understand what you're supposed to do. Know which ones are okay to live with for a while and which ones really should prompt you to visit your local emergency room. Make sure you understand why we do certain interventions. Why do we defibrillate certain dysrhythmias? Why do we do drugs first, then CPR, then evaluate them for defibrillation? Whatever you do, make sure you understand the difference between the AV heart blocks: first degree, second degree type 1, second degree type 2, and third degree heart block. These all have their own very unique set of presentations and their very unique set of treatments. That concludes the cardiac lectures. Thank you very much.